Good afternoon. I thank the Fondazione Menarina International for the invitation to talk and share with some of my colleagues some thoughts about coronary artery disease. Coronary artery disease is a complex disease, and it is complicated by many conditions like comorbidities. Among others, you have persistent angina and myocardial infarction, you have heart failure, you have hypertension, you have diabetes and other metabolic abnormalities like lipids, you have abnormalities in kidney function like chronic kidney disease, and finally heart failure. We know for a fact that there are established modalities of treatment, and among these modalities you have aspirin, you have statins, you have beta blockers for post-myocardial infarction, and you have the ACE inhibitors, and in contraindication situations you can use ARBs. Many of these drugs are well documented by large clinical trials, and they come by way of a class 1 recommendation in many of the guidelines, whether European or US based. We do have guidelines locally in the Philippines and in the Southeast Asian countries where almost the same drugs are utilized. For patients with complicated coronary artery disease like heart failure, we refer to a classic study like a seniors trial, which in most instances what appeared to be a contraindication for beta blocker use has now been an approved and established indication for beta blocker use. But in contrast with the previous beta blockers, the shift has been towards the so-called cardioselective beta blockers and those beta blockers which possess the special vasodilating properties. One of those beta blockers that possess a unique vasodilatation property is nebivolol, and we note that together with carvedilol, bisoprolol, metoprolol, nebivolol possesses the property of reduction of cardiovascular events, and therefore will ensure greater survival for patients even with complicated CAD going into the heart failure state. And so we note that there is at least a 30% reduction in the cardiovascular overall and cardiovascular mortality, which is a benefit that we see in most patients with CAD, especially afflicted with heart failure. Now, when patients have diabetes, we look at treatment of coronary artery disease that will not deteriorate or worsen the present present glucose or glycemic control. If you look at the data on glycemic control shows that with the addition of nebivolol, there is no significant effects in terms of abnormalities of carbohydrate metabolism, as well as new onset diabetes or worsening of diabetes. If you look at the chronic kidney disease factor, you will note that among others, or unlike ACE inhibitors where chronic kidney disease may be a consideration in modifying treatment, the use of nebivolol was associated with greater likelihood of obtaining the same effects without deteriorating kidney function. So in more ways than one, the beta blockers with unique vasodilating properties by nitric oxide metabolism represents a major advantage, because even in patients with chronic ischemic heart disease where you have PCI or bypass surgery has been done, there is still persistence of ischemia and angina, and this is explained on the basis of microcirculation problems. And if you use special beta blocker like nebivolol with nitric oxide stimulating property producing vasodilatation, it has been shown that coronary flow reserve has been increased, which is translated into great benefit in terms of controlling persistent angina even post PCI or coronary artery bypass. And so therefore, exciting prospects have been shown in patients for our therapeutic armamentarium for coronary artery disease, even in the more complicated cases like comorbid events or situations. Thank you.